Welcome, everyone. We're recording now. Thank you so much for coming to the Social Justice and Mental Health Research Lab speaker series. Today, we have Shauna Perez, who's been doing some really important and exciting research looking at moral distress experienced by living, who are working rather in housing and homelessness services, and in particular with a focus on service restrictions. So it's a topic that most of you are probably very interested in. I am currently situated today on Mohawk territory in Montreal. And I have the honor of working on the traditional territories of Anishinaabe, Haudenosaunee, and Huron-Wendat. I also work on the land of the Lenape and the Chinantan nations, and I recognize that Indigenous persons were the original caretakers of this land, and I feel privileged to work on this land as a settler. So I'll hand over the helm now to you, Shauna, and
Thank you everybody for coming. As you heard, my research is on moral distress experienced by service providers in relation to service restrictions, working with people experiencing homelessness. The part of the research team includes myself, Carrie Marshall, Nick Kerman, Aaron Dej, and Cheryl Forchek. So what is moral distress? Andrew Jamieson first described moral distress as occurring when an individual knows the morally correct course of action but is prevented from performing the action due to institutional constraints. Since 1984, the definition of moral distress has widened to encompass a variety of morally undesirable experiences with or without constraint, such as uncertainty, conflict, or compromise to morals, sense of responsibility to poor outcomes, and exposure to ongoing unfixable suffering. Symptoms of moral distress can be physical or psychological, and the experience of repeated moral distress can lead to mental health decline, burnout, personality changes, and potential trauma. Service providers play a critical role in contributing to positive outcomes for people experiencing homelessness. They provide essential services such as shelter, basic needs, housing supports, outreach, mental health and addiction services, and crisis response. To meet the needs of people experiencing homelessness, service providers need to be knowledgeable in multiple domains and have the skills to deal with complex behaviors and relationships with patience and compassion. Research has found that positive encounters and relationships with service providers were found to improve the well-being and were essential to effectively meet the support needs of persons experiencing homelessness. Here we go. A service restriction occurs when a service provider partially or fully denies a person experiencing homelessness essential needs services, either temporarily or permanently. Research from both service providers and individuals experiencing homelessness have found that service restrictions were frequently implemented in response to behaviors perceived to compromise safety, organizational roles, or service environments. Service restrictions were often perceived by individuals experiencing homelessness as unfair and exclusionary, increasing emotional distress, marginalization, and risk of harm. At the same time, service providers described significant ethical and emotional tension when enforcing service restrictions as they attempted to balance safety with the potential for harm to vulnerable individuals. The current study aimed to identify how moral distress was experienced by service providers working with persons experiencing homelessness in the context of service restrictions. Service providers were asked to describe their experiences of service restrictions, referring to personal and witnessed experiences. We conducted interviews with 16 participants located in Belleville, Kingston, and London, Ontario. We recruited participants by reaching out to leaders in shelters, mental health organizations, and drop-in programs. We also attended staff meetings at organizations to recruit potential providers. Service providers were eligible to participate in the study if they were over the age of 18, communicated in English, and worked as a service provider with persons experiencing homelessness for at least 1 year. Semi-structured interviews were conducted with service providers who met the inclusion criteria at the time and location of their choosing. Interviews were done in person using an audio recording device or online using a Zoom platform. Participants were asked to complete a Qualtrics survey prior to the interview, where consent was obtained by checking a box in the survey. The Qualtrics survey also collected demographic data and asked additional short, non-standardized questions. Interviews were transcribed word for word using a professional transcriptionist. The transcribed interviews were uploaded to Deduce, a cloud-based qualitative data management program. Interpretive phenomenal, I always have a hard time saying this. Phenomenological analysis was used to code transcripts line by line to derive meanings from individual participants, highlighting personal experiences of moral distress in relation to service restrictions. Patterns were identified and codes were created from data using quotes, descriptions, meanings, interpretations, and explanations. After codes were created, themes were developed based on experiential statements, connections, and patterns. The codes and themes were developed by the principal investigator, who presented the themes to the research team for input and made several revisions before the analyzation was deemed as complete. So we're going to talk about the qualitative findings. Interviews ranged from 43 to 74 minutes. Findings from the demographic data revealed that the age of participants ranged from 22 to 74, with equal representation of men and women. Most of the participants identified as white, while others identified as Asian, Hispanic, Latina, mixed race, or Mohawk. Participants also represented diverse sexual orientations and worked across a range of frontline and leadership roles within homelessness, mental health, addiction, shelter, and drop-in services. Most participants were employed in permanent full-time positions, although levels of direct work with persons experiencing homelessness varied considerably. Findings from the short, non-standardized questions indicated that involvement in service restrictions were common among participants, with over 2/3 involved in temporary restrictions and nearly 1/3 involved in permanent restrictions within the past year. Most participants reported feeling only somewhat safe in their roles, while experiences of threats, verbal aggression, intimidation, and hostility were common, with 3/4 reporting exposure to these behaviors in the workplace. Nearly 1/3 of participants also reported experiencing racial comments or insults. Although no participants reported physical injuries from service users within the last year, 1/4 described experiencing psychological harm related to their work. The essence of this analysis was "It hurts my soul," which refers to the turmoil service providers go through in the context of implementing or upholding service restrictions as they work to help people experiencing homelessness. This essence was expressed through 3 themes. This is part of the job, you just have to do it. It's very, very gray, and a lot of it's left up to our discretion. And the biggest risk for frontline staff and the biggest source of moral distress is around imposing service restrictions. The theme, "This is part of the job, you just have to do it," captures the sense among service providers that certain tasks and situations are inherent to working in the homeless sector. Participants described service restrictions as an unavoidable, sometimes daily part of their job. Implementing service restrictions was viewed as not being aligned with their helping role, and for many, it was emotionally taxing, induced anxiety, and conflicted with their personal values. Service providers felt that they were expected to just suck it up and do it, noting that there was very little empathy or acknowledgement of how difficult it was to deny services to the very people they were trying to support. It was agreed that the main purpose of service restrictions was to ensure a safe environment to work and receive services. Participants explained that service restrictions were commonly imposed in response to disrupted or aggressive behaviors, violence, threats, rule violations, weapon possession, theft, property damage, and behaviors perceived to compromise safety. Depending on the organization, service restrictions were also implemented in response to substance use, visible drug paraphernalia, or suspected drug dealing on property. As part of their role, service providers worked with a variety of different people who were experiencing homelessness. They encountered human traffickers and trafficked individuals, sex trade workers, people with sexual disorders, criminal behaviors, people carrying weapons, substances, addiction behaviors, drug dealers, predatory behaviors, mental illness, and physical illnesses. There were many aspects of the working with persons experience that were viewed as routine. These aspects included witnessing violence, dealing with death, verbal and physical aggression, threats, breaking up fights, and other behaviors and incidents. Service providers believed that it was their job to manage all client behaviors, and this was articulated by one participant who said, "It's your job to make people behave well, or have people to be polite, or not racist, or not sexist, or to be sober, or clean, or is it your job to help people not freeze to death?" Ted. No. Staff describe incidents where they had seen clients sustain serious injuries, including stab wounds, bullet wounds, head injuries, and other severe wounds resulting from fights between clients. They also recalled events where they witnessed clients punch themselves in the face, run into walls, be stabbed during a fight, and become violent due to deterioration of mental health. Several staff described incidents where they had to physically intervene to reduce harm to individuals fighting during their shift, with some staff members intervening during knife fights. One participant stated, "If I'm feeling physically unsafe, it's typically because there's an altercation between the clients themselves. But I see my role as trying to minimize that or mitigate that or break up the conflict." Freak. Other participants stated, "I've treated machete wounds, I've treated stab wounds, bullet wounds. There's really not much that I haven't treated." That was John Doe. And another participant stated, "All I heard was screaming, and the fellow, he was in a wheelchair, and he kept hammering his head against the washroom door. He had split his head wide open." Steve. Um, Other staff recounted experiences where they had been physically assaulted or threatened while working their shift. Although these aspects were not written as part of the job description, some participants were required to be trained in nonviolent crisis intervention, indicating that violence could be a part of their job. The following statements were made by participants. So there are times when I've been threatened with violence and assaulted, providing service restrictions. Cameron. And there have been incidents where clients have been trying to throw fists at me and trying to punch me or put their hands on me. So that has happened many times. There's going to be a lot of quotes here. I'm not going to be reading every single one. I'll just highlight a couple. Um, here we go. Another inherent part of the job is being yelled at, name calling, threats, violence, or dealing with death. Specific examples of aggression towards staff included having someone get right up in your face, physical intimidation, hostility towards staff, swearing, being rude, name calling, and coming into the space escalated. Participants recounted experiences where they received death threats. That was stated by Sarah Smith. There's been times where I've been on property and I've had to give some service restrictions and been threatened with very credible threats, stated by Eric. And you know what? We don't feel safe going out to our cars, even though the clinic is closing. He's verbally threatening, and we know from his history that he does have a violent history when he's in psychosis. That was said by Samantha. Um, Participants consistently describe service restrictions as a last resort rather than a first response. Many emphasize attempting alternate approaches first, including de-escalation, conversation, problem solving, warnings, disengagement, and involving community supports. Providers discuss balancing safety concerns while preserving the dignity, with preserving dignity, relationships, continued access to services, recognizing the significant consequences that service restrictions could have for persons experiencing homelessness. The following quotes illustrate how participants felt in relation to service restrictions. We try not to give service restrictions unless we have to. Alicia, I guess, for me, you kind of just suck it up and go along with it and try to implement as best as you can. Steve, nobody comes into this work wanting to get into an altercation or kick a client out. That's not why we come to work. Nick. The theme is very, very gray, and a lot is left up to discretion, reflects the uncertainty surrounding service restriction decision making. Participants describe service restrictions as complex, subjective, and difficult to apply consistently. Participants explain how provider values relationships with clients, approaches to care, workplace dynamics, and organizational processes influence when and how service restrictions were given. Many describe ongoing tensions between maintaining safety and providing compassionate, individualized, trauma informed care, emphasizing that service restrictions are rarely felt straightforward in practice. Service restriction decision making was perceived as being complicated by the relational and helping orientated nature of frontline work with persons experiencing homelessness. Providers described deriving meaning and purpose from building relationships, advocating for clients, and supporting individuals through complex circumstances. As a result, actions that limited or removed access to services often conflicted with the participants' moral and professional commitment to help others. Participant described persons experiencing homelessness as appreciative, trustworthy, respectful, and deserving of dignity and compassion. Many spoke of feeling safe around clients, emphasizing with the trauma they'd experienced, and developing strong relationships characterized by mutual care, affection, and protectiveness. They emphasized the importance of treating people as equals, building rapport, listening, offering flexibility and choice, and approaching people with empathy, compassion, and understanding. Providers stressed the importance of creating supportive environments that promoted safety and dignity, including clearly communicating expectations, modeling respectful behavior, providing opportunities to prepare relationships, repair, and maintaining supports even when service restrictions occurred. Service providers spoke with pride about advocating for persons experiencing homelessness. Many described going beyond their formal roles, challenging institutional barriers, and at times opposing organizational decision efforts to support clients. A quote by John Doe stated, I try to do the best I can, and think if it was me sitting there, what would I want this worker to do? How would I want this to go? Because providers invested heavily in building relationships and rapport with clients, implementing service restrictions were often described as emotionally difficult and damaging to the therapeutic relationship that they worked hard to build. Participants expressed concern that service restriction could undermine trust, discourage future help seeking, and negatively alter how clients perceive them. Many hope to repair relationships following a restriction. However, people did not always return after being restricted. Interpretations of when a service restriction was needed varied considerably. Many discussed how differences in perceptions, values, belief systems, tolerance, education, training, relational dynamics, and life experiences played a role in how and when a service restriction was given. There was considerable variability in how safety concerns were interpreted, with some providers issuing restrictions in response to swearing, verbal hostility, or talking back, while others felt restrictions were warranted in situations involving physical violence or imminent risk. While others only felt that it was were warranted in situations where physical violence and imminent risk was apparent. Participants described how similar client behaviors could result in different outcomes depending on the staff involved, contributing to perceptions of inconsistency and unfairness. Restrictions viewed as unjust often resulted in distress among providers. Participants describe organizational variability and how service restrictions were handled, ranging from manager-led approaches to frontline staff-driven decision-making. In some organizations, the responsibility was shared with frontline staff initiating the restrictions and managers determining the duration. Service restrictions were frequently implemented in moments of crisis, requiring staff to make rapid decisions in high-pressured situations. Service providers expressed discomfort related to the impact and consequences that emotionally charged rapid decision-making could have on people experiencing homelessness, especially in circumstances where police needed to enforce a trespass despite the visible distress and resistance of the person. Following a service restriction, the person experiencing homelessness did not always know how long they were restricted for. This was seen to happen in situations where the person left quickly or where the manager needed to decide a time frame on the service restriction. Service providers discussed how timeframes on service restrictions could vary considerably, with restrictions ranging from weeks to lifetime bans for the same incident. These timeframes appeared to be dependent upon who the client was, with more likable clients receiving less time and difficult clients receiving more time. Participants described increasing difficulties for persons experiencing homelessness to regain access to services following a restriction, with many viewing the process as punitive and inconsistent with accessibility of basic need services. Reentry often required a meeting with management, which in some cases took weeks to occur. These meetings typically focused on reviewing the incident and discussing strategies to prevent future restrictions. However, frontline providers were often excluded from this process, creating challenges in repairing therapeutic relationships and leaving staff to manage ongoing relational tensions on their own. Following a service restriction, the person experiencing homelessness didn't always know how to appeal unfair service restrictions. Although some organizations had complaint processes, these processes were difficult to navigate. Um, difficult to navigate. Advocating to remove or shorten restrictions was experienced by providers as frustrating and mostly unsuccessful, as it was rare for a service restriction to be overturned or shortened. Participants also discussed how restrictions imposed by one service often extended to other services despite no additional behaviors occurring. Service providers stated that debriefing following service restrictions was also an area of concern. While some organizations incorporated debriefing into their programs, many only offered debriefing after critical incidents, leaving providers with limited support to process the distress associated with implementing or being involved in service restrictions. Service providers described ongoing tension between following rules consistently and responding to people in compassionate, individualized ways. Some felt strict black and white approaches did not account for the person's circumstances, while too much discretion created inconsistency and confusion about when service restrictions should occur. Service providers emphasized that behaviors leading to restrictions could not always be understood in isolation, as trauma histories, mental illness, substance use, grief, suicidality, and broader life circumstances often shaped the client's behavior. Many service providers were uncomfortable with service restrictions that were applied uniformly because they did not consider the individual context or the sequence of events that contributed to the behavior that resulted in a service restriction. Service restrictions that focus solely on behavior rather than the person as a whole were viewed as potentially harmful to both the helping relationship and fair decision making. Participants emphasized the need for clear guidelines, more collaboration, and greater consistency between staff and leadership. Some also suggested that scripts structure guidance for difficult situations could help staff respond more consistently. Relationships with clients, compassion, and understanding of trauma were also described as influencing whether rules were enforced or restrictions were implemented. Participants explained that knowing a client well, recognizing their progress, or understanding the reason behind their behavior often made restrictions more difficult to impose. Some providers described bending or selectively enforcing rules when they felt policies were unfair, too strict, or inconsistent with their values. Distress was especially strong when organizational rules were perceived as dehumanizing, such as searching belongings, confiscating survival-related items, or restricting people for illegal substance use. Several participants questioned whether some restrictions supported clients' well-being or instead contributed to further exclusion and conflict. participants also reflected on how workplace stress, emotional exhaustion, and burnouts could influence service restriction decision-making. Long shifts, repeated exposure to crisis situations, and ongoing behavioral challenges were described as emotionally exhausting. Despite these challenges, many providers continue to struggle with balancing safety, accountability, compassion, and fairness in highly complex situations. Additional training was viewed as necessary to reduce uncertainty and better support frontline staff working in high acuity environments. Training in nonviolent crisis intervention, applied suicide intervention, trauma-informed care, mental health, substance use, and harm reduction were viewed as particularly important when working with people experiencing homelessness. However, several participants noted that organizations were not always able to provide this training due to funding limitations. A lack of training and uncertainty were also perceived as contributing to escalations that resulted in service restrictions. Participants described how limited knowledge related to trauma triggers, mental health, substance use, crisis response, and de escalation could negatively impact interactions with people experiencing homelessness. Increasing complexity among the clientele was another major concern raised by participants, particularly in relation to mental health, substance use, and behavioral presentations. This was exacerbated by increasingly harmful substances that alter behavior, intensify crises, and increase the risk of overdose and death. Many felt organizations had not adequately adapted to these changes through sufficient staff training or support, leaving frontline workers unprepared to respond effectively to increasingly high acuity situations. Oh, it didn't go. Theme 3. The biggest risk to frontline staff and the biggest source of moral distress is around imposing service restrictions. That was by George. Due to the insurmountable constraints embedded within the social service system and the nature of their role, service providers could do everything right to help a person experiencing homelessness, but it wasn't enough. Moral distress was commonly found in situations where providers invested heavily in their clients, going above and beyond. This was highlighted in the following quote. I'm here in the supportive role. There's only so much I can do. I can use every tool in my belt to help support this person, and sometimes bad things will still happen. Ted. The act of issuing a service restriction produced negative feelings and was perceived as conflicting with the service provider's moral value of helping. Following a service restriction, participants reported a range of intense emotional responses, including feeling sick to their stomach, anxious, guilty, devastated, ashamed, disappointed, worried, and even angry. Several participants stated that they felt like a failure and noted that following a service restriction, the incident continued to weigh on them, leaving a lingering sense of distress. Other participants described continually thinking about the incident and wondering if they could have handled the situation differently. Others felt severely impacted by the outcome of service restrictions, engaging in unhealthy coping strategies such as avoidance and suppression. Moral distress was also experienced when people were subjected to negative consequences following a service restriction. Restricting a person to sleep outdoors was often considered unsafe and dehumanizing, as it increased vulnerability, criminal activity, exploitation, trafficking, overdose-related harms, and complications from untreated wounds. Avoidance of service restrictions were discussed as being higher during the winter months, with only the most serious and high-risk behaviors warranting a restriction when temperatures were extremely low. Additional moral distress occurred when providers witnessed or enforced restrictions they perceived as unfair, unnecessary, inconsistent, or implemented without attempts to de-escalate. Distress was also heightened when service restrictions were related to long-term or permanent bans, as many providers believed that people should have opportunities to return and demonstrate change. Restrictions were viewed as particularly unfair when they were increased during the same incident based on assumptions related to incidents occurring off property or connected to behaviors associated with mental or physical illness. Unfair service restrictions were highlighted in the following quotes. If a client speaks their mind, says their opinion, whether it's calm, whether it's escalated or not, they are handing out service restrictions. I've seen multiple times where staff at the agencies will purposely try to get clients agitated and escalated so they don't have to deal with them, and then they have a reason to kick them out. John Doe. Also, it's just like once the person's been banned, it's like they're banned forever. Laney. Um, Adding to the chaos and inconsistency of service restrictions was seen to lie within the system itself. Participants described experiences of frustration and moral distress, portraying the system as overwhelmed and bursting at the seams. A condition they felt was constrained their ability to help people experiencing homelessness. Service providers spoke of inadequacies and dysfunction between agencies, shelters, and the police and the community as a whole. System constraints included a lack of sorry, a lack of adequate affordable housing, difficulty navigating the system to get required services, not enough services or long wait lists for treatment, and not having enough places for people to go to get a break from the streets. Participants described challenges related to the responsiveness of external systems and agencies during crisis. They recounted situations where they waited hours for assistance from police or other agencies, or where no response was received at all. Some participants questioned whether service restrictions should involve law enforcement at all, arguing that these situations reflected social service issues being addressed through a criminal justice framework rather than a social justice or care-oriented approach. Organizational leaders also described experiences of moral distress related to broader funding and resource limitations, particularly when financial constraints restricted their ability to adequately train, support, and retain staff. Um, this was a particularly powerful quote. Um, yes, I leave my dog outside in the backyard for a week. I'm going to be effing arrested, charged, and the dog will be taken away, and I will never be able to adopt another dog again. But we leave thousands of people outside to freeze to death all year round, and nobody bats an eye about it. So because they're just substance users and people have mental health, nobody gives a crap about them. Nobody in a position of power, anyways, gives a crap about them. That was John Doe. Participants described experiencing moral distress in response to the stigma people experienced in relation to homelessness, mental illness, and substance use. In addition to being restricted from social service settings, many people were described as being trespassed from restaurants, shelters, hospitals, medical offices, leaving them with few safe indoor spaces where they could rest without being removed. Providers describe witnessing individuals being routinely moved along from public spaces by businesses, service providers, or police in response to community discomfort surrounding visitable homelessness. Participants described these experiences as dehumanizing and emphasized how repeated exclusions further marginalize individuals and expose them to unsafe and inhumane living conditions. Stigma and discrimination were also witnessed within external systems, including hospitals and healthcare settings, which participants described as lacking client-centered approaches. These negative experiences were viewed as contributing to service avoidance and mistrust among people experiencing homelessness. Substance use was identified as a particularly stigmatizing issue, especially within abstinence-based services, healthcare settings, and the broader community. Participants highlighted how individuals who use substances were frequently blamed for their circumstances and perceived as choosing their addiction, resulting in an oversimplification and stigmatization assumptions that failed to recognize the complexity of substance use and homelessness. The mental health system was also described as a major contributor to moral distress, particularly when people with severe mental illness were unable to access the supports they needed. Participants described many high acuity individuals as falling through the cracks of the system. Individuals experiencing severe mental illness were often seen as being at greater risk to receive service restrictions, not only because of safety concerns, but because their behaviors or level of distress exceeded staff capacity or disrupted service environments. Restrictions were described in response to behaviors such as self-harm, escalating behaviors, yelling in response to hallucinations, delusional beliefs, and other symptoms associated with mental illness. Individuals experiencing psychosis were viewed as particularly difficult to support, as altered perceptions of reality sometimes created safety concerns for both clients and staff. These situations created significant emotional and ethical distress for providers, especially when restrictions were viewed as a response to unmet mental health needs rather than intentional wrongdoing. Although higher acuity individuals were recognized as presenting increased challenges within services, many participants felt that these individuals required more specialized support than the current system was able to provide. Differences in staff tolerances toward mental illness was also discussed, with trauma-informed approaches being more commonly extended to individuals whose symptoms were viewed as less disruptive. One participant stated that we all get tired of it. We would all get tired of it if that was where you had to live and sleep and eat. And there's people around you screaming that Jesus is coming to get you right now. And you better stand up and you better get down and you better pray. Yeah, the guy's crazy. Haha. But after a while, it's like, shut up. Like, I can't take this anymore. That sort of thing. George. Experiences of moral distress were frequently tied to feelings of powerlessness within the service restriction process. Service providers described hierarchical decision-making structures in which frontline staff were often responsible for implementing restrictions, but had limited power to influence decisions surrounding their application, duration, or reversal. The discomfort of issuing service restrictions was additionally related to how persons experiencing homelessness would perceive them when they had to use their power. Tensions surrounding power emerged across multiple levels, including relationships between frontline staff and management, providers and clients, and institutional responses to homelessness. One participant articulated this experience of powerlessness by stating, so that goes, I think, with the feeling of powerlessness. There's no good discussions happening. There's no consensus. There's no compromise. If somebody tells me to do a service restriction, I issue a service restriction. It doesn't matter whether I agree with it. It doesn't matter whether it's trauma informed or not. There's a hierarchy and there's a chain of command, and I play my position. So that, I mean, affects me on a day-to-day too. Obviously, there are changes that I would like to make for sure, 100%, but I'm not the one in charge. I'm not the one writing the policies. I'm not the one revising them. That's not in my wheelhouse. Freak. Although service providers largely described feeling safe within their roles and relationships with clients, many recounted experiences and where their sense of safety was disrupted. Feelings of unsafety were further intensified by experiences such as needle stick injuries, predatory behavior from clients, threats of violence, fears of disease or fentanyl exposure, inadequate support during escalations, working alone due to staffing shortages, and incidents of physical assault. Service providers often described willingly placing themselves in high-risk situations to support higher acuity clients, particularly when strong relationships had been established or when they feared the individual would otherwise fall through the cracks. Due to being restricted from other services at the same time, participants who felt unsafe in these situations often felt unable to voice their concerns as reluctance to take risk with personal safety was sometimes perceived as a lack of care or compassion for clients. Oops. Service restrictions were experienced as morally conflicting, particularly when when providers felt punitive responses that contradicted to their identity as a helper. Participants described significant distress when restrictions were perceived as harmful, excessive, or unjust, with some identifying these experiences as contributing to their decision to leave their roles. In addition to moral distress, participants described experiencing a range of psychological and emotional impacts associated with their work. Although some providers reported developing strategies to separate their work from their personal lives, many described carrying emotional weight of service restrictions home with them. Traumatic experiences were especially pronounced when providers implemented a service restriction and later learned that the individual had experienced significant harm during the restriction period. Others recounted performing CPR on individuals who had overdosed, well restricted from essential services, as well as witnessing overdoses, violence, and stabbings within the community. Historical trauma in service providers could also be triggered in the working context, with situations involving aggression, verbal hostility, violence against women, and behaviors associated with alcohol use. Following a triggering work-related event, in participants reported experiencing heightened anxiety, anger, fear, flashback, nightmares, emotional exhaustion, hypervigilance, and avoidance of future escalations or high-risk interactions with clients. Due to a lack of organizational supports, many providers discuss feeling responsible for managing their own symptoms. While some organizations offered EAP programs, employee assistance programs, participants noted that services were frequently restricted to only a few counseling sessions, and some reported having negative experiences that discouraged future help seeking. Participants also emphasized the importance of accessible counseling, clinical supervision, and support, visible leadership to help staff cope with emotional demands of the work and sustain their well-being within the frontline roles. Over time, many providers describe becoming emotionally worn down, cynical, detached, or feeling changed by the nature of their work. Repeated exposure to suffering, trauma, dangerous situations, death, verbal abuse, and service restrictions often led to emotional desensitization. Some participants expressed guilt about becoming less emotionally reactive over time, especially when comparing themselves to other workers who continue to respond more emotionally. To cope psychologically, many providers described emotionally distancing themselves from clients or avoiding close relationships. For many, these experiences extended beyond isolated moments of moral distress and developed into what participants described as moral injury. Ethical conflict and gray zone decision making were described as part of the everyday frontline work, with one participant describing the repeated experience of being unable to help as gut-wrenching. Another participant stated, "You can only care so much until you just can't care anymore. And then people are just putting their heads down and doing their job, and their care button is broken." Lou. Okay. So this study demonstrates that service restrictions place service providers in conflicting roles as helpers, protectors, rule enforcers, and gatekeepers of essential services. Organizational and systemic barriers often prevented providers from helping in the ways that they believed people needed. Participants were distressed not only by difficult situations, but by feeling unable to provide the care they believed was right. These findings also challenge Black and white approaches to behavioral enforcement. Participants emphasized that behaviors must be understood within the context of trauma, mental illness, substance use, grief, emotional distress, and broader life circumstances. Additionally, findings support trauma-informed, individualized approaches that focus on the whole person and the context of the situation. Moral distress was also found to be intensified when providers had strong therapeutic relationships with individuals experiencing homelessness. Although service restrictions were viewed as necessary, they were also experienced as harmful to vulnerable individuals. Participants also described trauma, violence, and crisis as being a normal part of their working environment within the frontline homeless service work. Limited training, inconsistent supervision, lack of debriefing, poor psychological safety, and inadequate organizational supports increased the emotional burden on providers. Findings also suggest that moral distress is not inevitable and can be influenced by workplace culture, policies, leadership, and staff support. Participants identified possible solutions, including clearer policies, collaborative decision-making, trauma-informed approaches, debriefing opportunities, improved supervision, psychological safe workplaces, and stronger staff supports. Overall, the findings suggest that moral distress and homelessness services reflect broader organizational and systemic barriers that constrain the ethical and compassionate care that service providers are able to provide. And that's it.